Imagine you're seeing an older patient, maybe in their late 60s or 70s, with left ventricular hypertrophy that checks the boxes for hypertrophic cardiomyopathy. The diagnosis seems straightforward, but what if it isn't the whole story? You're listening to audio abstracts on ReachMD. I'm Dr. Hallie Blevins, and today I'll be talking about the TTRACK study, which took a closer look at how often transthyretin amyloid cardiomyopathy, or ATTR-CM, is hiding in plain sight among patients labeled as having hypertrophic cardiomyopathy, or HCM. And just as importantly, it asked whether the nuclear imaging tools we rely on every day are actually doing their job consistently in the real-world practice. The investigators enrolled 766 patients aged 50 years or older, all with left ventricular wall thickness of at least 15 millimeters and no clear cause for hypertrophy. Patients with known sarcomeric mutations, prior amyloidosis, or severe aortic stenosis were excluded. This was very intentionally a population where the diagnosis of HCM looked reasonable but wasn't fully explained. Every patient underwent technetium-99m labeled bone scintigraphy using one of three tracers, DPD, PYP, or HMDP. Some patients also had SPECT imaging, though this wasn't mandatory. Nuclear scans were read by on-site experts and then reviewed centrally using the Perugini grading system to assess myocardial tracer uptake. If uptake was present, monoclonal protein testing followed to separate ATTR-CM from light chain amyloidosis. Now let's get into the results. 18.8%, so nearly 1 in 5 patients, ended up with a non-invasive diagnosis of ATTR-CM. That's a striking number for a group already carrying an HCM diagnosis. And it reinforces a point many clinicians are starting to appreciate, which is in older patients, hypertrophy doesn't always mean hypertrophic cardiomyopathy. About 90% of patients had planar scintigraphy alone, which reflects routine practice. Despite that, agreement between on-site readers and centralized experts was strong, with a cap of 0.84. Clinically meaningful disagreements were rare and in only about 0.5% of cases. Planar imaging was remarkably consistent to SPECT, with a kappa of 0.93. The few discrepancies that did appear were limited to PYP imaging and involved only minor grade differences that didn't change diagnostic classification. One of the more thought-provoking findings came from comparing radio tracers. ATTR-CM was identified in 26.9% of patients imaged with HMDP, compared to 11.7% using DPD and 6.4% using PYP. Whether that reflects tracer performance, regional practice patterns, or patient selection isn't entirely clear, but it does raise important questions on how tracer choice may influence detection rates. When the investigators looked beyond nuclear imaging, they found patterns clinicians will recognize, but none that could stand alone. Patients with ATTR-CM had slightly lower ejection fractions, higher left ventricular mass indices, and more frequent preserved apical strain. Concentric hypertrophy was also far more common than asymmetric patterns. On MRI, late gadolinium enhancement showed up in about 85% of ATTR-CM patients, compared with about 55% of those without cardiac uptake. ECGs also differed, with longer PR intervals, lower Sokolow indices, and more conduction abnormalities. The message from the TTRACK study is practical. ATTR-CM is common in older patients with unexplained hypertrophy, and nuclear imaging, especially planar scintigraphy, performs pretty reliably in everyday practice. Imaging patterns and ECG clues can help, but they shouldn't be definitive. But the real shift here is conceptual. For older patients, an HCM label should prompt deeper evaluation and not diagnostic closure. This has been an audio abstract, and I'm Dr. Hallie Blevins. To access this and other episodes in our series, visit reachmd.com, where you can be part of the knowledge. Thanks for listening.